Good morning, everyone, and welcome to Pediatric Grand Rounds, our hybrid Grand Rounds. We invite you to come and join us today in our LPCH auditorium. We'll start, as we always do, with our land acknowledgement, acknowledging that Stanford sits on the ancestral land of the Muwekma Ohlone tribe, and that this land is of great importance to the Ohlone people, and we want to stand consistent with our values of community and inclusion, and the fact that we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native people. Today's session is in recognition of Asian American Pacific Islander Heritage Month, and we have Vicky Ng with us today to speak with us about optimizing outcomes in pediatric liver transplantation, something for everyone to care about. Our next two pediatric grand rounds are first the Richard Behrman Endowed Lectureship in Pediatrics, where Judy Shader from the American Board of Pediatrics is going to speak with us. And then on June 2nd, we'll have Sean O'Leary from the University of Colorado School of Medicine speaking with us about strategizing for communicating with vaccine-hesitant parents. Our two upcoming MCHRI seminars are nothing that you want to miss. So on Monday, May 22nd, we have a hybrid seminar in the Red Oak Dining Room at CAM or online via Zoom with the Ayer Blumfield from OBGYN and Kunj Seth from Urology, speaking with us about challenges and opportunities for fetal and pediatric device development. And then on June 6th, we also have another hybrid session with Tamar Green from Psychiatry and Behavioral Sciences, talking about pathways to provide clues for the etiology of neuropsychiatric conditions. Starting in the fall, we'll be moving to a new location and a new date on Tuesdays from 8 to 9. We'll still be hybrid, where we'll be in the Grand Rounds room in Pediatric and CAM, because this room will be undergoing construction. And so you'll notice that we'll be focusing on having in-person Grand Rounds at CAM when we have our speakers there, and then we'll have virtual grand rounds on on days where we have internal speakers. And so now we'll turn it over to Dr. Sohail Hussain to introduce our speaker.
Thank you, Baraka, and good morning, everyone. My name is Sohail Hussain. I serve as the chief of the GI division. It's my pleasure to introduce Dr. Vicky Ng, who is professor of pediatrics at the University of Toronto and medical director of liver transplantation at Sick Kids or the Hospital for Sick Children. Dr. Ng did medical school at the University of Toronto, Peds residency at Sick Kids, a pediatric GI fellowship at Cincinnati Children's, and since 2000, she's been on the faculty at Sick Kids. She's an international leader in pediatric GI and liver transplantation internationally. She is past president of the Society of Pediatric Liver Transplantation, or SPLIT, as it's known, and president-elect of the North American Society of Pediatric GI Hepatology and Nutrition, called NASPGHAN for those aficionados. She has over 165 peer-reviewed publications, mostly in pediatric liver transplantation. She's the co-creator of the Pediatric Liver Transplant Quality of Life tool, which is used in teens across the world. She's been the site PI for almost half dozen NIH-funded consortia or trials. And today, as we've heard, she'll talk to us about something that hopefully relates to all of us in some way, using liver transplantation as an example, and it's about outcomes. So please save up your questions or comments, which you can ask in person or pose on the Zoom Q&A. And now please join me in welcoming Dr. Vicky Ng, our North American colleague.
Thanks so much, Sohail, for that very kind introduction, and good morning to everyone. So first of all, I just wanted to thank the Grand Rounds Committee for this great invitation and opportunity to come speak to you today on this topic, optimizing outcomes in pediatric liver transplantation, something for everyone to care about. It's really an honor to just reflect as this month of May being Asian American, I'll rephrase it, Asian North American and Pacific Islander month. And it caused me to just sort of reflect back, particularly in my new role, which I adopted in October of 2022 as NASPGHAN president-elect, about, from where we were to where we are and where we're going. And so I want to introduce you to Mom and Dad, Edmund and Jenny Lee, who this is pictured actually shortly after they were married. And I think one of the most sort of intriguing things as, kids growing up was to understand how at that time in their 20s in Hong Kong, they were sensing challenges ahead. And they were actually seeing that there was potentially an option, an opportunity for change. And through communication and collaboration with my dad's sister, who had actually relocated to Toronto a couple years prior, they summoned the courage for their children to be. And so there enters an opportunity for my dad, who was a social worker in Hong Kong, and my mom, who was a seamstress, who actually didn't speak English, to summon that courage because of what they thought was an opportunity for the children and the future to be who they could be. And so fast forward, you've heard kindly from Dr. Sohail, sort of my journey in Toronto, and venturing south of the border as a newlywed with a Canadian husband and who couldn't work for 3 years. I was in Cincinnati. I think we actually also experienced a lot of those challenges and change and really kind of, I think we're somewhat spoiled in Toronto being a very multicultural place. And truth be told, my dad was contemplating between going to Vancouver or San Francisco or Toronto. And so landing in Cincinnati, Ohio, we actually definitely experienced many opportunities where we had the opportunity to educate on diversity. And I remember one of the first things as a fellow in Peds GI at Cincinnati Children's Hospital, I had to do diversity training. And one of the comments that I said kind of in jest that, as an Asian and a female and Canadian, like what part did they really want me to further, learn from each other? But fast forward, it takes two Canadians to procreate my firstborn. He was actually situated second last from the back here in this picture when we took him to see the Great Wall of China a few years ago, proudly toting a Toronto Blue Jays cap because he cannot still find a Bengals cap. Because indeed, in my fellowship years, he was born in Cincinnati. And one of the biggest things that I actually sort of encountered in terms of diversity being an opportunity with intent to educate was that I told you that my surname was Lee, and I published by the name of Vicky Ng. Perhaps incorrectly, I took on my husband's surname, whereas there's a story with this, is that shortly after Jonathan was born, I actually got a phone call from the Social Security office, and a very kind lady with a slight Middle West draw said to me, "Hello, ma'am. I just really want to make sure that you know that your surname has no vowels." So that was definitely an opportunity for us to really, have an opportunity to talk about, that it is possible to have surnames and it's pronounced as if there's an I in front of it. So here we are right now in Toronto with another child who, while my oldest cannot get a Bengals cap, he has stopped gloating to his younger brother that he's an American, but Matthew isn't. So on we go. So because you can see, I'm trying to stick with the theme of C's. One of the things that my parents actually really, in coming to a land of opportunity, always talked about the importance of the children, which obviously makes it sort of relevant that I'm a pediatrician, but it also actually talked about giving back and charity. And all through the years growing up, I remembered my dad back in those days always sending a check back to my grandmother, his paternal grandmother, funds because of the opportunity that he had in Toronto. And so this is a picture of the first of 2 medical missions trip that we took our kids to an orphanage in Kenya. And I think it's a really good opportunity. And I have to say, honestly, as we talk about all the opportunities I might share about microaggressions, this one is not a microaggression. So I mentioned that it's hard for people to say Dr. Ng the first time around, but no one had problems saying Dr. Vicky. But quite frankly, in this setting, I was always Matthew's mom or Dr. Vicky. So I think that's really, really important. Okay, so with that in mind, I think I'm going to start with my learning objectives, which are listed here. I'm going to give a little bit of what I call Pediatric Transplantation 101 for those of you in the audience that may be less sort of aware of some of the current basic points of pediatric transplant. Where are we now? I think you see the theme about knowing where we're going very much is needed to know where we are presently. And I want to end off with really just trying to illustrate, I think, of where our patient population is going that really requires and mandates the engagement of all pediatric healthcare providers. And I think it's important because as pediatricians, we strive to hear the voice of the patient. And I think there's a lot in the outcomes of pediatric transplant about making the invisible more visible for the betterment of this patient population. So let's start off with the case, shall we? So 7-month-old female, I think these are patients that you would probably see somewhat regularly here with biliary atresia. In Canada, patients can have the first initial surgery at one of a number of pediatric hospitals across the country, and so it was performed in Atlantic Canada, in Eastern Canada. Unfortunately, the jaundice did not clear, and by 3 months post-Kasai, it became clear to that team, which did not have a liver transplant program, that perhaps they ought to be referred to a pediatric liver transplant program. And by the time we saw her at age 7, she looked like this. And I think that really notable on physical examination is a jaundiced baby with an NG tube, yet she has a very distended belly. And if you were to get really close, you could actually see that her arms and legs are very spindly, very reflective of growth failure already at 7 months with a liver that is not working well. And I just highlight some key points with the conjugated bilirubin that in the non-SI units would be 4 milligrams per deciliter of conjugated bilirubin, but with a total bilirubin well over 6. And already there's a sense of a low drifting down albumin and an INR that's creeping up. So on that basis, if you remember that patient, I'm going to talk now what I call the 5 W's of pediatric liver transplantation. It's what I call the who, what, where, when, and why. And because I'm not a surgeon, it won't be so much of the surgical how, but there'll be some nuances of the medical how and how all of us can be part of the how do we help pediatric liver transplant survivors have the best life possible. So who are the patients? And I showed you this picture of our patient who is clearly very persistently jaundiced due to a failed Kasai and persistent cholestasis. These patients oftentimes can develop coagulopathy, either at presentation, as in acute liver failure, or progressive, as I'm highlighted, the INR was already 1.5 at 7 months of age. These kids oftentimes with liver disease or liver failure that come to transplant already are showing signs of severe malnutrition, or I'll just say malnutrition that could become severe and lead to growth stunting. And one of the really challenges things is that sometimes the weight may not be so reflective. And why this picture tells is that the ascites can offset an otherwise quite low weight child who's not growing well. Complications of portal hypertension can sometimes come, and that's really important because sometimes these kids who are having significant life-threatening variceal hemorrhages that we can't control endoscopically and they're getting ulcers from sclerotherapy may not actually have a very high bilirubin or may not yet be failing to thrive. And as well, they may have refractory ascites that are actually really stressing out the kidneys because of really aggressive medical management. And that action itself can be really significant reasons for early referral to liver transplantation. And then I always say that as liver doctors, we care about the other organs, and indeed liver failure can affect the heart, the lungs, the kidneys, and the brain with all the hepatopulmonary syndrome, hepatorenal syndrome, hepatic encephalopathy. And then selected metabolic conditions can just come in and have really significant, debilitating, make you feel like you want to itch because they are so pruritic, and yet they may not necessarily have all the earlier signs of liver failure and diseases such like Alagille syndrome or some of these inherited genetic cholestatic syndromes. And then finally, liver cancer, which by far is the most common reason for liver transplant in adults, does happen in kids in the more form of hepatoblastoma rather than HCC, and the metabolic liver conditions with their significant impairment with quality of life because of these really, really rigid medical therapies, or these very fragile kids that as soon as they get an intercurrent cold, their ammonia shoots up and they actually can have significant neurocognitive crises. I show this slide just also to really highlight the multicultural nature of Toronto. So the makeup of our patients, race-wise, would show that almost a quarter of our kids in Toronto who undergo liver transplant are Asian or mixed Asian background, which as you can see from my standpoint, even though I do not speak Cantonese very fluently, there is definitely something to be said that when you see a doctor who looks like you, I have a partner who's Israeli, and every time there's an Asian patient, it's like, Vicky, will you take this patient? And I think it gives some empowerment to the families and to the kids as they grow up. And what are the most common medical conditions that actually lead to this phenotype? So what I showed you initially is the phenotype, whether or not you have biliary atresia or you have primary biliary cirrhosis, which is an adult disease. They have the jaundice, the coagulopathy, the portal hypertension. But for the kids, I'm sorry, I don't know how that been correct actually. If you just look over here, it should have actually not cut off the screen. You can see that biliary atresia is still the most common reason for why children need pediatric liver transplant now in 2023. And it used to be more like 50%, but I think because of the success of pediatric liver transplant in terms of patient survival, the piece of the pie that's attributed to metabolic liver conditions is now sort of pushing to 15 and sometimes even 20% of a large center's volume, is actually making the proportion of biliary atresia not quite half. Pediatric acute liver failure continues to be a common presentation in a large center with about 15%, right? And those are often the most devastating. And from a pediatrician or ER standpoint, if you see a child that kind of comes in with a high INR that's not explainable, you have to worry about acute liver failure. And some of the comments I may make about having weeks or days even to kind of work things up kind of goes out the window, and you're restarting fresh with a very fulminant presentation and indication for liver transplant. And seeing Dr. Berquist in the audience, you'll probably, those of you who've ever taken care of, likely cross paths with Dr. Berquist. All right, so where is liver transplantation happening? Clearly across the United States, but I thought this might be interesting for you to know that in our very geographically wide country of Canada, with a population of 50 million, we have 3 liver transplant programs for kids. So that's not one for every province, in contrast to almost 1 adult program for every province. And adults don't do kids under 18. And so about 60% to 70% of those transplants are done by sick kids, because you can see one on the west in Edmonton, which kind of does, the British Columbia and Saskatchewan, and then Montreal, which is pretty close to us geographically, but is more French speaking. So a lot of the Atlantic Canada will come to Toronto. Okay, but just so that you know that liver transplantation now in 2023 is standard of care. It's been amazing how 20, 30 years has been lifted from a moratorium of, we did not have cyclosporin until the early 1980s, and pretty well since 1984, 85, 86, depending on your program, is when pediatric liver transplant programs started popping up. But you can see here that there's lots of registries for pediatric liver transplant patients. That gives you an idea that, we're not alone. These kids will have long-term patient survival. And the European Liver Transplant Registry recently published a paper of over 16,000 liver transplants in kids in a registry fashion. And then every year here in the United States, the UNOS, SRTR, the Scientific Registry of Transplant Recipients, issues a report where you can see a lot of demographics. And I see Dr. Narang here, who will easily be able to tell you lots of data that can come from this annual report in terms of numbers across the country at different sites and their outcomes and many other data variables. I'm going to, as you heard from Dr. Hussain, I was previous president of SPLIT, and so Society of Pediatric Liver Transplant has been a very important longitudinal liver transplant database. Dr. Berquist, I think, was one of the founding fathers of this over 25 years ago, and it really adds and complements the UNOS database by giving a lot of longitudinal data. By pediatric liver transplant centers that centralize on pediatric transplant, whereas the UNOS is mandatory reporting. You get results sometimes that can be marred a bit by centers that may only do 1 or 2 every year, or even 1 every other year. But clearly liver transplant is sort of emerging, and now there's a lot of interest to try to ensure that kids from sort of the third world countries also have access to liver transplant. And there's been efforts by some of our international societies to try to map out sort of where the global, the status is, with the idea that lots of patients can fly to potentially other countries for transplant as they're evolving, and a lot of surgical education of people flying over to potentially try to train these centers. When does liver transplant happen? I think it sounds kind of funny, but I mean, it happens when an organ becomes available. And I think for the purposes, just so when we talk, you'll understand, for those who might not necessarily see transplant patients regularly, standard of care in 2023 still remains liver transplant with an organ from a deceased donor. And when you hear from a patient who had a deceased donor organ transplant, you always do want to know, did they get a whole organ? Which makes sense, right? It's a deceased donor. You could take the whole thing. But a lot of our kids, and biliary atresia being so common, you would imagine that the median age for liver transplant is about 18 months. So a lot of like the smallest adults at 60 kilos, 70 kilos, and we know adults nowadays are a lot bigger, will not fit in. And thanks to surgical techniques, we've been able to do what we call technical variant grafts. So you take the deceased donor liver and you size it down based on segmental anatomy, and you can actually do what we call reduced grafts, and you actually take down 2 or 3 lobes, or a left lateral lobe or a left lobe, put that into the baby, and then you chuck the rest. take the right and check the rest. And that just seems really, really wasteful. And over the years, in the past couple of decades, many surgeons have really honed, and I know Stanford is a major surgical leader when it comes to split graft, so a 2-for-1, where you actually have one organ that you can actually appropriately surgically size down. And it sounds easier, like what's the big deal? Is because every portion of the liver needs its own outflow of blood and bile ducts, and sometimes you don't have enough length, or there's other various sort of technical issues that make the initial technical variant more like you take what you need and you throw out the rest. But you can imagine how weightless could be tremendously sized down if we could do for one. Clearly, supply demand is totally imbalanced, and live donor liver transplantation was first innovated in the early 1990s, in large part because of the split technology. If what we're really saying is that you don't need all of your liver to live, you can take some of away and you still have another portion to give someone else, then couldn't you do that with a live person? Take a portion, probably a left lateral lobe was how it started, save somebody, and then the donor would still have more than enough liver plus all the vascular and biliary anatomy that I was talking about and have a very good life. Okay, and I'm going to talk a little bit about this and how it's really been seized by the Toronto program because of our own challenges with deceased donor organ access. And why is liver transplant necessary? There's lots and lots of Kaplan-Meier curves that you can look out there. I thought from the context of us being in North America, I would show you the data that was recently published by our split database. And one can actually see in red line, this is patient survival going up from 5 years right now from transplants done in the last decade. And you can see that 5-year survival of 95% across all diagnoses is really incredibly high. If you compare this with the adult numbers, which is probably more in the 70 to 80%. And if you stratify that curve by primary diagnosis, you'll see that biliary atresia probably is even better. And probably diseases like hepatoblastoma or pediatric acute liver failure with probably something immunological are the ones that kind of bring the curve down a little bit, sitting maybe about 80% of 5 years. Okay, so let's go back to our patient with that sort of, hopefully now we're on the sort of same page and sort of foundation, is that our patient got listed and then she underwent a liver transplant with a live donor graft from her dad. As her mom would say, that she brought her into the world, but dad let her continue to look like this. This is actually less than 2 months out from liver transplant, totally clearing of jaundice. And I have to say, it's one of the most incredible things about being a transplant hepatologist is actually seeing the clearing and lifting of the scleroicterus, which can be deep sometimes in yellowness, even within a couple of days of a functioning graft. And I think that these parents not unexpectedly had a number of questions. And I think this is the one thing that I really want to sort of permeate through my conversations. I talk about optimizing outcomes, that I'm speaking from the lens of an academic clinician, which is my job activity profile and Toronto SIG is, which means I don't have a lot of protected time to do research and to write grants like the scientists and investigators, but I'm so grateful because it's the parents who ask the hard questions. And it's the parents that actually kind of make you think and go back and say, how was the last 10 patients? What about the next 10 patients? And so I'm going to sort of answer some of these questions about expected outcomes, monitoring, what's her life going to be like from the context of seeing 30 to 40 liver transplants per year in a program that's been around for about 30 years. So this is a pictorial that we, a sort of a working group of both adult transplant hepatologists and pediatric hepatologists. And remember, my title is something for everyone to care about. So one of the things we really wanted to engage early on was to have our adult partners, because these kids are going to transition and transfer to adult care. And we actually came up with what we thought was a really good analogy when it comes to thinking, how can we help these kids? And I think one of the most important things I really want to list is how to help these kids doesn't happen just at the time of transplant. Like thinking, oh, everything will be better at the time of transplant. It actually backdates this to thinking about identification of the patients. So something for everyone to care about is if you see a patient who's jaundiced, right? What's the diagnosis? Like what's happening? Have you seen a liver transplant program? And in terms of social determinants of health right now, we know for sure that you can't get transplanted if you're not identified. You can't get transplanted if you're not listed. And you also certainly can't get transplanted if you're not referred to a transplant center. So this is the lens that I think a lot of people in our community, and we have leaders such as Dr. Noel Ebel here as part of social determinants of health interest, that's really trying to champion some of this at the local level. If you move along this journey of timely listing, also the time on the wait list. You know, obviously you're on the wait list for a reason. You need a transplant. Unfortunately, we're not in a state where we can just order an organ the way we can order a blood transfusion or order antibiotics. So there's this wait period. And the wait period, depending, you know, what it is like in your geographics, can be long. So minimizing comorbidities and being anticipatory and knowing what's the natural history of liver failure or, you know, other things such as we talked about metabolic, you know, liver conditions is really, really important for pristine medical management. So in the interest of time, because I know potentially there are a lot of things that one could talk about as we look ahead, I thought we could target 4 things that our center has recently tried to innovate and actually has been now sort of permeating our academic community, and some of which the Stanford liver transplant program has also embraced really heartily, and I'm going to call it as well. So I'm going to talk about sarcopenia, which is something linked with liver with malnutrition. I'm going to talk about the outcomes across the different graphs, because I talked about, reduced split. So parents would like to know, well, if I get a split graft, I'm not going to have as good an outcome as if I get a whole graft. I'm going to talk about the use of live donor organs and an innovative use using anonymous live liver for liver transplant. And I'm going to talk about an initiative to try to raise awareness of liver organ donation and transplant using the power of youth. Okay. So sarcopenia. So sarcopenia refers to unintentional skeletal muscle mass loss that's typically seen with elderly people. And it's now very well published that adult cirrhotic patients on the waitlist are all pretty well sarcopenic. And patients who are sarcopenic who undergo liver transplant have higher rates of complications post-liver transplant. So again, the idea of backdating the way we can help the outcomes goes before transplant. And how to assess sarcopenia in adults has been established for well over a decade. And it's using CTS assessment, a slice of your abdominal muscles to measure the area of the total psoas muscle. And there's actually cutoffs for what's normal and what's not normal. A North American expert opinion group published an article in 2019 that basically said that this actually is recommended for assessing for sarcopenia and severe malnutrition and drive therapy. Now, in kids, obviously, we have kids that are 2, we have kids that are 8, we have kids that are 17. You can't use the same sort of cutoffs as you would use for a 35-year-old or 45-year-old or 25-year-old. And so around a couple of years before this statement kind of came out, single centers were already demonstrating that if you look at children with end-stage liver disease, this is for transplant, and you look at their total psoas muscle at the intervertebral lumbar area, you'll find that it's actually lower if you actually had a couple of other CTs of similar age and gender-matched children. That doesn't seem very satisfying, does it? That you'd actually have to go searching for a normal child of the same age. And so what we did actually in realizing that this is actually such a problem, and by the time you can think this patient's sarcopenia, because I can eyeball the spindly arms and legs, you've probably missed a couple of months at least of nutritional rehabilitation. So we actually worked with our trauma surgeon who had a trauma database with over 1,000 CT scans of children who come into the emergency room with abdominal trauma. And after tossing out all kids that may have had comorbidities, kids that may have neuromuscular problems and other things, we actually honed in, and we've actually been able to create now age and sex specific growth curves if you actually can measure the psoas muscle area. I could talk lots about it, but radiologists have proven that it's actually replicable between radiologists. So if you go on this web link here and you type in the age and the date of the CT scan and what level and what the value is, you'll get a picture like this. You'll get a dot, a growth curve, and you get a Z score. And you might imagine if the Z score here is 26 percentile, 0.83, then you're probably not as worried as patients that we definitely have Z scores minus 3 point something, minus 4 point something. And it always seems a little bit trite, but by the time you see it, it might be a bit late. Okay. I'm going to move fairly quickly. I'd love to take questions. The second thing I want to just sort of raise is what you say to a family that says, hey, you're a GI doctor or you're in pediatrics and Stanford has an amazing program. What do you think about my baby getting a split graft versus getting a whole graft? Isn't a whole graft better? Well, that was a question that we actually probed the split database. And with transplants that were done after 2011, with almost 2,000 transplants, we actually found when we compared 3-year patient and graft survival outcomes with Kaplan-Meier curves between deceased donor whole, deceased donor reduced, where you toss out what you don't need, and deceased donor split, and live donor liver transplantation, the take-home message is there was no significant differences in either patient or graft survival based on graft type used in almost 2,000 transplants. And so I think with this paper and numerous other ones as well that are really now pushing, and there's obviously an element of surgical expertise, that widespread routine use of technical variant grants should be strongly encouraged to try to decrease waitlist mortality and morbidity for children on the waitlist for liver transplantation. All right, moving right along to live donor liver transplantation. I'm going to tell you, this is a very unusual graph about liver transplant volumes that are done with a live donor liver transplant. So if you look actually, if the 50th percent, if you look on the y-axis, 50%, so 50% of our annual activity is live donor liver transplant. You'll see that starting from about 2013, 2014, every year, more than half of our liver transplant activity is with the aid of an organ from a live donor. Supply-demand imbalance is significant. Plus, obviously, there's a lot of comorbidities with donors being obese. Steatosis doesn't make for good cold preservation time. And so we actually then looked more and critiqued our experience with over 135 live donor liver transplants to try to answer the question, is there a difference in outcome between using a live donor versus a deceased donor organ? And one can see here that in purple, that most of the donors, 69% of them, came from related donors. Moms were the most common parent over dads, and then there were aunts and uncles and cousins. One can see in green that they're emotionally related, so not biologically related, but godparents, neighbors, friends of the parents of kids, and 8% of our cohort. I'm going to talk about the yellow piece of pie in the next slide. But what was really important is that we found that live donor liver transplant was able to decrease our wait time for our kids with end-stage liver disease like biliary atresia by almost 2 months, 57 days. If you think about our little baby, 2 months is an awfully long time to not be able to feed well and be really susceptible to line infections and things like that. And one can see with the blue line being live donor that our outcomes were superior, which is not to say you wouldn't use a deceased donor, but it really opens another way to try to shorten the wait time and trying to get these kids, if you let me say time 0 to transplant, so we can flip the chapter on trying to optimize their long-term outcome. All right, so I think I showed you this yellow piece of the pie, which reflects livers from donors who are anonymous to the recipient. And our Toronto Liver Transplant Program, which is a partnership, so all the live donors are worked up by our Toronto General Hospital Liver Transplant Program colleagues. We have a live liver donor office, was really sort of challenged in 2004 when a very healthy young man came and really challenged the paradigm at that point in 2004 of saying, why is it only live donors that have some sort of emotional or biological relationship to a recipient be allowed to donate? And this was a whole year of intensive ethical and medical and surgical and re-looking at all the complications with our cohort to date of live donor, and actually led to it happening, and it was in a pediatric patient. But more importantly, we actually published this actually as a case report to kind of set the framework, which subsequently guided our practice to date. And really, it really centered on the idea of critical scarcity of deceased donor organs, the excellent outcomes that we're seeing with the live donors of related organs, and more importantly, we wouldn't treat an anonymous donor any different. We'd be as meticulous, if not more so. That there was actually a lot of literature from other organs saying that there's positive psychological benefits for living anonymous donors, that altruism is a legitimate motivator, and that willingness to donate to a stranger, they're not crazy. They're actually, with this sort of extensive psychiatric sort of workup, is actually something that has been and could be done. And within the Canadian space, through focus groups, there seemed to be a general public acceptance of the idea. And I'd be curious just to see if anyone has any different thoughts in a different era. And I think even now the era might be different than when we started this in the mid-2000s. So this led, after that inaugural case in 2004, to a subsequent paper that was published in Nature Reviews, Gastroenterology and Hepatology, talking about the concept of anonymous live liver donors. And we did another 49 anonymous live liver transplants that went to 28 kids over the next 10 years. And what's really important is what here's in yellow is it represented about 6.7% of all our live donor transplant activity, but more importantly, 2.4% of all transplants. So really it meant that if we did 50 of these, that's 50 more patients that were off the wait list and potentially, able to use a deceased donor organ that would have not been available to them had a similar patient not already been transplanted with the anonymous live donor liver transplant. And since that time, we did the 28 in that first 50, we've done over 60, I think we were 62 actually as of last week, pediatric recipients of anonymous live liver donor. And one can see over here on the column on the right that we started off with that index case of 1 in 2004. And then in the next 5-year period from 2006 to 2010, we did 6 anonymous transplants for kids. And then we did 3 times that, 14. And then from 2016 to 2020, we did 24 anonymous live liver transplants out of our overall denominator. And I think that this has really become a very valuable alternate way of using live donor liver transplant in our hands because of our observations with how limited our supply chain is for deceased donor organs. And so this is going to come to the fourth thing, which I want to talk about how we've innovated and try to, control things that sometimes we can't control. As physicians, we know that we can control certain things. We can work a live donor sooner, but we still have to deal with the fact that our deceased donor rate was so low. And back in the early 2012 or so, we had a patient death on our donor list. And this was a patient that was trying to identify live donors, and live donors were not being cleared for different anatomical reasons or medical issues. And it's always sobering when you have a death, because then you reflect back on what we've done. And at that point in time, what we did at this retreat is that we actually decided that, we're pediatricians. We talk to kids. We like you. And if you really think about it, youth are our policymakers of tomorrow, right? They're the people that are going to drive some sort of change. And if you look back at recycling and seatbelts, there was always an element of youth champions. So we thought, why not try to seize the idea that we don't mind talking to youth? We actually want to talk to youth. Youth always want to talk to me about what's it like to be a doctor. And so we thought, let's try to create an initiative where we go into the Toronto area high schools and talk about life-saving liver transplant as a transplant physician and tell stories. And what became really, really cool is that we actually would bring in a recipient. And so nothing cooler than having like an 18-year-old who had a liver transplant for metabolic liver disease, or a biliary atresia patient in university, and have these patients see pictures of them, like similar to what I showed you. And here they are in color, right? I mean, they're not listening to me. They want to see and touch, our patient. And that's what we did. And over the course of the next 10 years, we just had our 10th anniversary last April. We've done over 350 presentations. And what was really cool is that all the presenters with the recipient were a transplant surgeon, hepatologist, respirologist, cardiologist, nephrologist, gastroenterologist for the bowels. And we have given over 40,000 high school assemblies, classrooms, biology class. And here's a couple pictures of our chief of medicine at the Toronto General talking to a biology class. And ultimately, I think the feedback has been quite subjectively positive. And we did publish the experience because a couple years in, when we realized this could be that there was sustained interest by our school boards, we actually did a couple of surveys where we could actually look at students' perception and value and willingness to sign their organ donation card. And then after the presentation, would they? And we actually saw obviously statistically significant differences. Not perfect, but it's an idea that there's a lot of education to be had. And I think that the energy that came from hearing this, I think, is a lot more intriguing than actually having them see a module, or talking to them one-on-one. I think having that sort of community piece and having a physician come into their classroom was really amazing. And of course, I just don't want to leave the message that this is physicians. We had a huge outpouring of support from our allied health group, and we had a lot of nurse practitioners, nurses from the ward, social workers, psychologists, pharmacists, rehab medicine people going in. And it really became a two-tiered effort with regards to showing these students sort of the excitement of being in the medical field. Okay, so I'm going to quickly move on to talk a little bit about the outcomes from the gastroenterologist, hepatologist standpoint. And again, with data from the split database, one can actually see right here that while we're talking about great, patient survival, graft survival, that there are a number of other systems that really involve sort of collective care by all healthcare providers that may intersect with children at different points in time. I just really want to highlight that, renal function could be compromised pre-transplant, but definitely continues to be a problem post-transplant, in large part because of the medications that we use that can have a significant nephrotoxic effect. And so I think what really wants to drive home here is that, when you encounter a patient like this in the emergency room or in the acute care, or if they're coming to see you in endocrinology, something as simple as doing a blood pressure can actually be really telling, because these are sort of these subtle data points that are helpful serial in time and not just done at a one-off when we come and see them at their annual visits. Cancer, or PTLD, was actually seen in about 8% of our patients. What's really interesting is increased body mass index was seen in about 12% of this cohort of 5-year survivors, which really speaks to the growing epidemic of obesity medicine. And I think the idea that, post-transplant child, if we're trying to say, is actually trying to get as close to a normal life as possible, being sort of privy to some of the society's healthcare issues with fast food and supersizing and obesity is obviously another parameter if we really want the graft to survive for a very long time and not have a otherwise healthy transplant graft succumb to steatosis and cirrhosis from NAFLD. That can certainly be a theoretical fear by our community. And obviously looking at cardiovascular health, with diet, with high cholesterol and triglycerides is definitely something that is more prevalent than we may actually necessarily see on face value if you're not looking to monitor and survey. And so this paper is just really to highlight to you that even as of this paper published as a joint statement by and endorsed by NASPGHAN as well as ASLD, there have been published articles that say this is how you manage long-term a patient who survived liver transplant even back in 2013. And really what I want to highlight here with these different boxes, you can see that there's a lot to monitor. And again, I mean, endocrine issues and diabetes, type 2 diabetes and bone health, growth, psychosocial issues as they transition to adolescenthood, and screening for skin cancer, vaccinations, these actually permeate all of us as pediatricians. And I'm just trying to extract some of the things that actually hopefully we can engage as a community trying to, if we encounter a patient, let's just think about the things that I can actually survey. And I think that's particularly important because right now, generally speaking, with differences in center practices, most centers will see these kids once per year, maybe twice per year if there's a problem. And we'll do liver tests to make sure the graft's okay, maybe every 2 months, every 3 months. The pandemic, I think, has really heightened our awareness about, fears that parents may have. And I think the idea sometimes of parents missing an annual visit and maybe going 2 or 3 years without coming to clinic is a reality. So again, it really begs the question of being aware of some of the issues, because while they may refuse or not want to come and see us in the hospital because they're otherwise well, they may end up in a acute care clinic with a cold. They may end up in a merge with broken arm, broken leg. And I think these are some of the opportunities to seize by saying, oh, you've had a liver transplant. Oh, are you taking your medications? And know that this is currently the standard of care, that we're still tightly monitoring them. This is going to be the only slide on immunology here, but I just really want to show you that from right now in 2023, we still have a lot of options, but probably not as much considering that we've been doing transplants for well over 25 years. But tacrolimus or Prograf, FK, FK506 is probably universally the most common medication after 1 year post-transplant. If you see a patient who's 5 years, 10 years, 15 years post-transplant, probably they should be on a low dose of tacro, okay? If they say that they're on other medication, to me, that's a signal. Say, have you talked to your liver transplant program? Because typically they should be on a little medication. If they're on more medication, probably that graft hasn't been so healthy, okay, over the years. Oh, sorry, I don't know why I went backwards. Okay. Sorry. I just also wanted to just throw a couple of other names, even for name recognition. We have a lot of kids that may be on rapamycin or sirolimus for different reasons. And those could be that we've been trying to have them survive after cancer and don't want them on tacro. And medications like MMF and Imuram, which actually happen at the cell cycle level, is to me a clue. If someone says, I'm on something with letters or MMF, as well as tacrolimus, that maybe they've had rejection in the past, something that prompted their liver transplant program to feel that they would be better off with 2 medications rather than 1. So this is just another way to show you that there's many options and combinations of medications. And I think that I would just really draw your attention to the pink line, which shows that right now for the transplant that's being done tomorrow here at Stanford, or that'll be done next week in Toronto, we're still mainly using tacrolimus and steroids at the time of transplant. But we have a bunch of other protocols for unique scenarios if a patient has renal failure or a patient's coming in for cancer as their primary indication. And ultimately, I think by showing you this scale that, meticulous management of immune suppression continues to be the major driver for trying to ensure longevity with the graft. And I'll say right now that, we've been doing transplants for about 25, 27 years, that we really believe that a graft could go to 60 to 80 years, because realistically, our human life usually ends not by liver failure when we hit the average age span of a man at 75 or something like that. And so the idea of just optimizing that too much may actually predispose a patient to having a lot of the toxicities that many of you may have heard, such as infections or cancer, getting other organ failures. But having too little can actually oftentimes cause what I call subclinical problems. And we have kids that stop taking their immune suppression for a few weeks or a few months. You don't know it. And it's what I call that sometimes things are very invisible till you actually choose to kind of do more digging or more exploring or more monitoring. And ultimately, we can't have a talk about optimizing long-term outcomes, at least sort of mentioning what we still consider the holy grail of transplantation, that one day, hopefully in my lifetime, that we will be in a situation where we'll be able to have biomarkers that can predict which patients will have stable graft function, normal liver numbers forever, but not be on immune suppression. And it's what we call operational tolerance. And there's lots of single center experience that will show, handfuls of patients, but nothing that's actually standard of care anywhere in the world right now. And to that end, that is why recently there was a completion of an NIH funded study called IWITH, which looked to follow really meticulously a very selected cohort of really well kids and see how they would do after 4 or 5 years of being off immune suppression. And when I say carefully selected, these kids were carefully selected. They were kind of like the best of the best patients. So they had to be transplanted really young, that they had to be at least 4 years out with normal liver numbers. They couldn't have had rejection the past couple of years. They couldn't be on the extra medications that we were talking about. And then the real crux of it, we had about 160 of the patients who met this. We then insisted that they have a liver biopsy just to make sure that the invisible was okay. And what was really interesting is that we ended up actually only being able to withdraw immune suppression on half of these ideal kids, with half of them ruled out by the liver biopsy. So again, it's the idea of you don't know till you look. And it really raises the question about, gosh, if we had not done the liver biopsy, we would have immune suppression withdrawn on a greater number of patients and actually potentially had a very different outcome with lots of potential graft loss or graft function. So in the end, we had about 33 patients who were withdrawable and stayed off immune suppression out of an initial cohort of 88. But to get to the 88, we actually biopsied 160 or so patients. So, I think sometimes when you do a study, you actually kind of learn more from maybe some of the stuff you weren't planning on study. And so I actually was also very intrigued about, don't tell me so much about the 88 patients who got withdrawn off immune suppression. Tell me about the 160 minus 88 patients who couldn't be withdrawn off immune suppression because when we looked at their liver biopsy, we actually saw problems. And so Sandy Feng, who was the PI for the IWITH study, I was also the first author of this paper where we actually dove deep into those patients, or actually all the patients who had a liver biopsy in preparation for the IWITH study with perfect liver numbers, and everyone say, oh, pick them, like let's immune suppress withdrawal on these patients. And what was really, really intriguing is that pretty well, most of the patients, and the reason why it's 67 over 157 is 157 were the patients that were perfect, and we did biopsies on them. 88 had good liver biopsies, and we withdrew with them. So that remained about another 70 or so patients. Almost every one of them had fibrosis, as evidenced by this heat map that was actually a sort of like a no-go sort of read. Okay, so what was the real message of it to me is that, you don't know what you don't know. You don't know unless you look. And the idea of just the things, the data that we like to hang on to, they look okay, their bilirubin zero, the AST, ALT is all right, see you next year, may actually be telling us that we need to see stuff under the microscope that we would not know there's a problem unless we actually took the time to explain to our patients about doing a protocol liver biopsies. I'll tell you right now, we are not doing protocol liver biopsies for kids that are well empirically. Noelle, are you guys doing it empirically here in Stanford? Everybody's okay. There you go. How many? Okay. And I think that we're probably finding out. But this actually brings up this really intriguing paper. Again, I'm trying to say that we need so many, it's a team sport. We probably need our adult people really engaged. And I'm going to give a shout out to Dr. Narang here, who's really putting a spotlight on transition. There was a paper that looked at UNOS, looked at all patients who had a transplant before the age of 18. And what they were trying to see was whether or not there was a high risk age period where graft loss was most commonly happening. They'd already seen it in hearts and kidney transplants, and their vulnerable age was 17 to 24 years of age. And what we saw in this paper was that the vulnerable age for liver transplant patients, again, transplant as a kid, was 21 to 29. Now, I think, Dr. Narang can give you a lot of explanations about why that might be, but I think 21 is, frontal lobe, boys, 29, they're still an adolescent. I mean, who's watching them? Who's nagging them? Why are we having such good outcomes in our babes for the first 10, 15 years? There's something called moms and nagging moms, right? And I think there's a lot, and they're going to college and they feel well, and the invisible is actually, not known. And I think this is something that's really calling to our attention that, again, if someone comes into the emergency room with a headache or something like that, if they're a transplant patient, it really behooves us to ask, what medication are you on? When did you last see a liver transplant program? Okay, for the last 5 minutes, I just really want to draw attention to further diving deep into making the invisible visible and looking beyond sort of the obvious data that we actually seem to have mandated by protocols. And it's even back in 2008, there was this paper published, and John Bukovalis, who we know in the liver transplant world very well, was part of this group that said that quality of life and patient-reported outcome measures to date are all generic, and they're not helping us to understand how to make the lives of these kids better. And I think that it's so much more than just survival, and we've got to do some work towards visualizing the invisible. And so a patient-reported outcome measure is reporting from the patient's perspective on a number of elements of the broader determinants of health that we would not otherwise know. And it should not have interpretation by a clinician or even, quite frankly, a parent. And there's a list of potential benefits of it, which I think a lot of that is common sort of sense. I think what's really important is even PROMs now are a necessary outcome metric for any intervention by the FDA. So it really actually behooves us to say, what are we doing in our pediatric liver transplant world? And this paper just came out recently suggesting that solid organ transplant patients, research studies must have a PROM. And it highlighted that there was a lot of challenges in the pediatric solid organ transplant space trying to identify a PROM because of lack of knowledge, lack of confidence, and other barriers such as resources, like what will you do with the data, who will administer the data. But this is actually in the research realm. So I wanted to just sort of introduce, and I think Dr. Hussain had mentioned, this was something that spurred from that NIH workshop by Don Cavalis, where we actually thought, let's try to create a disease-specific tool specifically for pediatric liver transplant patients. So it's called the PELT-QL, Pediatric Liver Transplant Quality of Life. We engaged over 300 children who've had a liver transplant in Australia, England, Australia, Canada, and the US, interviewed them, taped them, extracted themes, reduced themes. We followed this established methodology, did a whole bunch of psychometric property testing, and it was published in the Journal of Pediatrics. And in a nutshell, it's a 26-item questionnaire, all one-line questions. You circle your answer 1 to 5. There's a version for the parent, there's a version for the patient, and you can do it if you're over the age of 8 and you're at least 1 year old post-liver transplantation. And it's about a grade 4, grade 5 English reading level. It looks like this in the paper. You get the first page, it has a sample question. You can circle your answer, and the questions look like this, and it'll ask you questions like, how hard is it for you to concentrate? How worried are you about transferring to a healthcare provider when you get older? There's a version for the parent, and the questions are reframed. How worried is your child about transferring to an adult care? How hard is it for your child to concentrate? I think those of you in the IBD world and in the other sort of EOE worlds and neuromotility know that there's probably disease-specific PROMs, and I think a lot of this is probably no different with IMPACT and some of these other quality of life tools. I will just hone in on one maybe little nugget of outcome findings, and I think Dr. Ng has been amazing in terms of our sort of collaborative spirit in actually bringing the PELT into the liver transplant clinic here in Stanford, is that you see these questions actually stratify out into subdomains. And although the questions come in an order that doesn't say you're going to do all the 9 future health questions first, and then there's 8 coping adjustment questions, when the patients are scored, one can really see that, in fact, parents tend to undercall the worry of parents about future health in our first review of our 150 patients. Meanwhile, they tend to be undercalling the subjectiveness. So they're not reading kids right when it comes to coping and adjustment. So they're saying they're not worried about future health when they are, and they're actually missing that their kids are actually having coping challenges. Just want to let you know that as part of the diversity thing, we've actually translated the PELT-QL to a number of different languages, and it's not just a straight translation, but it actually has what I call cultural adaptation and neurocognitive debriefing, where you have forward translation, backward translation, and then you actually have to apply it to 5 children in the native language, which you're applying to with a whole number of sort of like questionnaires and surveys before we can actually sort of validate and say it's actually a validated non-English version. We've actually trialed this out within a liver transplant learning network. And so in addition to the 150 or so that we've done in Toronto, there's been another 149 dyads who've done this across 7 different pediatric liver transplant sites. And it's showing that it's feasible. Parents like doing it. And the biggest singular thing that our network now is looking at it is that liver transplant clinics were saying it actually didn't even require increased resources. It's just remembering to build it into workflows that has kept it from being a sustainable practice. And Dr. Ng and I had a really great time yesterday as we are going to try to plow through to try to come up with ways to help educate our colleagues with developing into workflows and maybe trying to adapt the EMR to make it more easy. So spoiler alert is that I think we cannot be in 2023 and expect our kids to be excited doing something by paper. And so we've recently adapted it to have an iPad version. And the iPad version, you can already see right away. Everyone knows how to swipe, otherwise if you're like mother, you're like, where's the next button? You swipe away and you touch the answer instead of circling. And it's 1 question per screen. And it also helps you at the end to come back and actually readdress missed questions. And what's really beautiful when you finish this is that the clinician will get this. I'm sorry it's so small there, but you'll get an automated scored PDF sheet that will tell you the answer to every question and flag the questions that were scoring abnormally low. So that really, what are we hoping to gain right now is to hear their voice better, to try to create openings for discussion about matters that are important to them. And I don't know if anyone wants to take a guess on what question or what theme might have really popped up. We have about 25% of our Toronto patients that uniformly scored low on this question. They've had a liver transplant, they're doing great, but they circled abnormal, and 1 in 4 kids scored. What do you think a patient who's had a liver transplant may have issues long term with? It's their scar. Right, so there was a lot. So really, I have to say before we did this, I don't know how often I would ask about a scar of a 10-year survivor. I'm really interested in the scar when in the first 3 weeks, 6 weeks, looking for healing and whatnot. So I think it's just sort of really lends its idea to really listening and using this opportunity to see what matters to your kids. And you don't know if you don't ask and you don't dig. All right. But ultimately, in conclusion, here's really why we do transplant in 2023 and why I'm here today is that it's life-saving. It's more than just about the liver, that we have to pay attention to not just the quantity of life years restored, but the quality. And that there's a broad range of items that we need to continue to address as we learn. We don't have 40-year survival right now. We're only about 30 years out from transplant, 20 years with really good immune suppression. There's a lot of data to be had that's visible. We love lab work, we love ultrasounds, we love spleen measurements. But there's a lot of invisible data that we haven't really started to kind of really reflect on how we're going to capture it. And I think with PROMS, we can better hear the patient voice. So we can take this patient, and the mom made this cut the liver from the dad, and paste the liver into her. And here she is with her twin brother, taller than her twin brother, new baby. They're a family of 3, playing basketball, coming to visit us at on her 16th birthday. You can see she's the same height as me. And just really to say that it's a team sport. It takes a village to raise a child. There's something for everyone to care about, as I showed here with all the services. And I'm probably going to say it takes a healthy liver to raise a child. And when I talk about everyone, I'm going to expand the everyone that impacts and contributes to our theme of not just surviving, but thriving, is that we want our adult partners to really care and not say run away and say, oh, hang on to them until they're 21, 24, 28 or whatnot. The youth of our society can probably do a lot with social media to help us propagate this message if they knew some of the information. Strangers, it's phenomenal that we do anonymous live liver donor transplant. I'm going to say funding. Listen, where grants are hard to get by, right? If there's a philanthropist or somebody that wants to donate money like they do for IBD, Rosen, and it would be really, really awesome. And so I hope that that was a nice way to sort of hopefully get you energized and engaged that, pediatricians and primary healthcare providers, you're vital in the shared care and management of this patient population via multidisciplinary approach in the monitor, surveillance, and anticipatory pickup of both routine and transplant-related themes. So obviously there's a cast of thousands and team support with all the people. And this is our team. We have some amazing surgeons who allowed, who really allow us to start time 0. And I'm happy to take any questions.
I think we have only about 2 or 3 minutes. For those who need to take off at the hour, thank you for attending. For those who can stay, we might be able to stay for a couple more minutes beyond the hour. I just wanted to thank you. You've given us a lot to think about. You're motivated by your patients. You're starting as early as high school. You're also here because of Asian, North American, and Pacific Islander heritage, and it's sort of universal that science and medicine is a universal pursuit for all heritages. And I think you exemplify that. With that, does anyone have a question or a comment? We've got a microphone. Okay, how about 1, 2, 3? We got to do rapid fire.
Well, welcome and thank you. So the anonymous transplantation, it's wonderful and fascinating to me. So I was wondering, like, how anonymous? Like, does the donor or the recipient learn anything about each other? And then this is also one of my father's a nephrologist. He recently told me that he saw a patient who was a former donor, but that that patient developed kidney disease, and that actually raised their status on the list that they were a former donor. I was wondering if that happened in Canada or if that happens in liver here.
That's a great question. Okay, let me answer the first one. So is there, how anonymous? So it's anonymous. I think that actually raises a lot of interesting questions, which maybe we can talk about offline. But I think one of the things that's really important with our experience was the importance of the anonymity, because of the whole idea of actually people, there are people out there. So they actually really talk about the importance of anonymity. It's really easy on the kid side because we're a separate building. So to show how heightened the anonymity is in the adult side is they do them on two different, they recover on two different, they get admitted on two different rooms and they recover. Because you could imagine if someone really wanted to know, right? You see like a hepatectomy and whatever, right? And so they do go to great lengths. What we do offer the recipients, though, is the opportunity to write a letter that actually we then actually anonymize, and then we actually will give it to the donor. We've not had someone that subsequently needed a transplant, to the best of my knowledge, but that would be a very interesting thing. And I'm not sure that it would necessarily fly, but maybe we'd try to find them an anonymous life donor. So, all right.
Got two more questions here and here, and then we'll do a couple of online. But again, if people need to take off, thank you.
Hi there, I'm Ryan. I'm one of the chief residents, soon to be oncology fellows. Sorry if this is an obvious question, but can you speak a little to why you were saying that for kids with cancer that undergo transplant, sirolimus is a more appropriate pharmacological choice rather than tacro?
Yeah, no, thank you. That's actually a great question. And, I can talk for an hour just on immune suppression choices. That's great. So yes, hepatoblastoma is probably the most common cancer. And I'll just say, simply speaking, that the mTOR inhibitors, of which sirolimus is actually meant to be anti-proliferative. And I think you probably, as an oncologist, have known that it's sometimes used for a number of different entities, right? For hemangiomas, for instance. And so I think there's a general feeling that although from a patient selection standpoint, you're choosing sort of patients that have had full resection, we have published an experience that actually suggests that after that early period of 30 days, and 30 days being that there has been reports of sirolimus causing hepatic artery thrombosis, that we actually will switch them over. That sometimes stretches to 3 months if they need chemo. So we don't do sirolimus while they're on chemo, but once they finish their chemo, then we will actually do that. The second, I think, secondary benefit is RAPA is actually kinder on the kidneys than tacro, and a lot of our kids come in with extra hepatic comorbidities, whether from their earlier chemo and whatnot. So it just seems all around like a safer choice, but it's the anti-proliferative effect that actually drove that choice. So not an obvious question, and thank you for asking it.
You made me think about when you were talking about making the invisible visible. And so my question is, because you've been such a pioneer to say, like, here's a huge data set, let me query this one question, coming out with things that have really driven our field forward. My question is there a way to, is it more like the Starzl model? I'm just trying to think of, like, their data is there. How do you make it more of like a live dashboard? So is it like Starzl in that sense where you're like looking across all the centers, or we just started looking at our data through like a Tableau dashboard, and PCDK is going to be looking in real time, like what are the racial and ethnic disparities before and after transplant? What's the answer to just like tapping into that data faster?
Oh my gosh! Well, we need to talk because that was great. So I think right now the state of being right now for PROM use for clinical surveillance has kind of waned. It's epic pandemic recovery, busy clinics, patients not coming into clinic, clinics actually feeling kind of strapped to kind of have someone administer it and retrieve it. You've mentioned Starzl, which is the learning network, and I think that's where we're working right now with perhaps some of the more resource sites or sites that have very energetic young hepatologists like Dr. Ng to kind of start being able to come up with workflow suggestions. And actually, to what you're saying is looking at the data of a few sites, because I think what the sites are asking for is, can you give us some guidance so that if someone scores really low on this, like, what are you doing? So that they don't feel like either further fatigue, but now I know something, I've got to deal with it. So it's almost like kind of like, I don't know, so let's continue on. So I'm not sure I'm answering your question directly, but we don't have a lot of data right now in the Starzl network. I think the numbers of completed PELQLs are probably 2 sites or so worth, but it's 2 sites of data worth and maybe a third with Stanford that we actually may be able to move this forward. And I'd love to get your input potentially about how we could benefit from the EMR, maybe to make it work together with Amrita. Did that answer your question, Noelle?
Yes,
it's
perfect.
a very
Thank
packed
you.
question there, lots of layers.
I think we have to end. We had over 130 online participants, so let's give one last round of applause.